We now continue our discussion of Chapter 12. This is Lecture Chapter 12-3 on neuropeptide function. So we now consider the effects of neuropeptides on the neuroendocrine system. In the prior lecture, 12-2, we had talked about the effects on synthesis of ACTH through corticotropin-releasing hormone. We'll now think of it on a slightly broader scale with a bit different perspective. So the highest concentration of the neuropeptide cell bodies in the brain are in the hypothalamus and the median eminence, the areas which regulate the neuroendocrine system. Neuropeptides can alter hormone secretion by modulating the release of neurotransmitters, which stimulate neuroendocrine and endocrine cells. So we're beginning to formulate a picture of neuronal input to neuroendocrine cells consistent with the neuroendocrine transducer system that was introduced, or concept that was introduced in the prior chapter, Chapter 11. And all the neurophysiological events that we had talked about on membrane excitability, firing rate, pulse, bursting of the neurons, and as well impacts on release rate combined with synthesis, all come into play in considering this neuroendocrine transduction system of how the nervous system can transduce its events into, it's basically electrochemical events into endocrine signals in the plasma. So first we take a look at Table 12.2, the effects of selected neuropeptides on the neuroendocrine system. So now, of course, we also begin to see that it's not quite as clear-cut. There's a lot of interaction between various peptides and neuroendocrine axes. So the endogenous opioids, remember that opioids is the term for the endogenous system. Opiates, or opiates, O-P-I-A-T-E-S, is the term for exogenous, typically synthetic opioid acting agents. Anyway, endogenous opioids increase growth hormone, increase prolactin, and this is release that we would be thinking about increasing plasma levels of these. In an acute exposure, it'll increase ACTH, but chronically it will decrease ACTH. So these are some of the ideas to keep in mind. Is it acute? Is it chronic? Is it pulsatile? Is it constant? Is it given intravenously? Is it injected into the brain ventricular system, the intracerebroventricular system? The cerebrospinal fluid is the fluid that would receive it there. Is it injected directly into the brain? Is it intramuscular? Is it subcutaneous? Is it intraperitoneal? So route of administration becomes extremely important, especially in a general perspective from central versus peripheral administration, primarily because peptides do not cross the blood-brain barrier in significant amounts to produce profound effects, as we know. So the endogenous opioids decrease TSH, luteinizing hormone, varying effects on follicle-stimulating hormone. This is the one we're going to focus on here with our discussions for now. Decrease oxytocin and decrease vasopressin. I'm not sure if we could go across here and try to make sense of all these responses, but of course that's the effort that researchers collectively put forward to try to make sense of why a single set of hormones or hormone, maybe beta endorphin, would produce this wide array of effects. What does it mean for the organism as far as survival and reproduction would be concerned? Substance P provides us an example of a distinction between a central and a peripheral effect, and we'll just look at the growth hormone to make that example. Central administration of substance P into the cerebroventricular system, the cerebrospinal fluid, produces a decrease in growth hormone, whereas a peripheral administration produces an increase. And we see neurotensin has a similar effect in actually the same direction. I don't know if the potency would be the same or different. And we see from this list that there are only two of the hormone sets or hormones in the left column affecting both oxytocin and vasopressin. That's the endogenous opioids and the vasoactive intestinal peptide. So I'm just going to proceed from this. You can familiarize yourself with this table, but I think I pointed out enough distinctions for you to appreciate my perspective and how I might expect you to understand the information in this table. We are now going to continue with the consideration of the endogenous opioids affecting the hypothalamic-pituitary gonadal axis. So they inhibit the release of adrenaline from the adrenal medulla. We'll look at a few more effects first before we focus on that. Regulate the secretion of GI hormones, modulate the release of adenohypophyseal and neurohypophyseal hormones, as we mentioned in the previous table. The opioids stimulate the release of growth hormone and prolactin and inhibit the release of LH and FSH in both rats and humans. So this is where we want to go with this. Testosterone levels are reduced within 2 hours of morphine injection. We'll look at the graph of this information in just a moment. Inhibition of the gonadotropic hormones by opioids suppresses sex drive as well, so this might be why we observe low sex drive in heroin addicts in the human population. The opioids will also inhibit thyroid-stimulating hormone, TSH, release in rats, but not in humans. So there can be species differences as well added on top of the differences we pointed out in the table. Opioids will reduce the pulsatile release of pituitary gonadotropic hormones, the gonadotropins, and block ovulation and decrease testosterone. So it is inhibiting the pulsatile release of the gonadotropins, LH and FSH, and thereby we would suspect a central effect on GnRH release as well, and we'll consider that in just a moment. But first we take a look at the effects on testosterone. So the y-axis is testosterone, plasma testosterone concentrations in nanograms per ml, and the x-axis is time after morphine in hours. So you can see here within 2 hours of they're not showing exactly when I guess they took a control sample at this point, and then within 2 hours of administering the opioid. This is testosterone levels in male rats measured at 1 hour intervals after a subcutaneous injection of morphine at 10 milligrams per kilogram. The data, of course, are shown in values of mean plus or minus standard error of the mean. And we see that within 2 hours of administration, there is a significant decrease in the plasma testosterone that persists for up to just about 7 hours. At 6 hours, we still have statistically significant values from the control. At 7 hours, although there's a bit of variability, there's no statistically significant difference between this mean value and the mean value for the control levels. And then there's an overshoot at 8 hours with the beginning of stabilization, but look at the variability at the 10 hours. So recovery from this type of a hormone effect is not always stable and predictable. So the single asterisk is P less than 0.05. So that means there's a 5% risk of error in the data. So this has this very tall, you can't even see the upper part of that error bar, the standard error of the mean. So even though this is quite high compared to the control, the error bars just about overlap, so it's just barely statistically significantly different from the control levels. Whereas these very tight error bars, and so not much variability in the measurements, and the double asterisk is probability of p less than 0.01. So this is a strong, significant, statistically reliable and significant difference in comparison to the control levels. So it's 99% of the time going to be accurate. Continuing with our discussion of the effects of neuropeptides on the hypothalamo-pituitary axes, we can consider the effects of another effects of opioids on prolactin release, and this is mediated within the hypothalamus by an interaction between beta endorphin synthesizing and secreting neurons, their axon terminal shown here, acting through the mu opioid receptor through an axoaxonic interaction or synapse on the hypophysiotrophic dopamine neurons, the tubero-infundibular dopamine neurons. So we see that it is inhibitory. So this mu receptor is decreasing the likelihood of exocytotic release of the dopamine in this terminal. I was just looking to see if the authors mentioned if the mechanism is known. We can now almost predict either effects on increasing potassium efflux, hyperpolarizing the membrane, so when an action potential comes, the magnitude of the polarity difference or effect on the membrane in the axon terminal is blunted, attenuated, so not as many voltage-gated calcium channels will open, or it may even impact the voltage-gated calcium channels, making them less efficient. So even though the action potential gets here of the same magnitude, it cannot get enough calcium in to cause the exocytosis that would normally occur. So presynaptic inhibition of release of dopamine by beta endorphin mediated through the mu opioid receptor. If we decrease the amount of dopamine reaching the lactotrophs in the anterior pituitary, the dopamine is normally inhibitory, then we are releasing these cells from an inhibitory input, so we disinhibit the prolactin secretion of the lactotropes, and prolactin levels should increase in this case. So this is an example of a disinhibitory circuit. So we are inhibiting an inhibitor, and we disinhibit that which was inhibited. Think about that for a while. But it is an example of disinhibition within a controlled system. In panel B of figure 12.9, we are seeing an example of how we might be able to explain negative feedback of gonadal steroids on the Gnrh neuron. So the gonadal steroids, as well as the contribution or inhibition of Gnrh, very likely if we decrease the pulsatility of the gonadotropins, LH and FSH by endogenous opioids, we are going to decrease the pulsatility of Gnrh release. So how might that occur? And the way that that can occur is basically shown here. If we increase the amount of opioid acting at these axoaxonic interactions on the noradrenergic neurocrine input to GnRH neurons, the increased opioid activity through the mu and the kappa opioid receptors will inhibit the axon terminal, decreasing noradrenaline release onto the postsynaptic GnRH neurons, and thereby we are taking our foot off a gas pedal. We are inhibiting the drive to the system. So we have a presynaptic inhibition of the excitatory drive to the GnRH neurons. I better be explaining that correctly. Yeah, so what they're showing here is that the noradrenaline is the gas pedal. It excites or impacts through the alpha-1 adrenergic receptor the GnRH neurons, such that there is an enhanced pulsatility and release of GnRH that would lead to an increase in LH and FSH. So if you increase opioid activity presynaptically on the noradrenergic terminals, then you take your foot off the gas pedal, and in the prior example, we take our foot off the brake. We disinhibit. In this case, we take our foot off the gas pedal, and we reduce GnRH neuron pulsatility and release of GnRH, and we would decrease LH and FSH, decrease the LH, and of course you've got the decreased drive for the synthesis and secretion of the testosterone, as we had seen in the prior figure, the graphical figure. So this slide explains how that occurs, but it also helps us understand how gonadal steroids can impact the synthesis and release, decrease synthesis and, increase synthesis and release, had it backwards, of the beta endorphin and dynorphin in this circuit. You increase synthesis and promote release, and you increase the inhibition of noradrenergic release. You take your foot off the gas pedal, basically you've got a negative feedback. So we'll talk later about the GnRH neurons not being the prime candidate for direct feedback of gonadal steroids, and this is one way in which the negative feedback at the level of the hypothalamus has been described and discovered. So indirectly through neuronal circuitry, gonadal steroids will increase the synthesis and release of beta endorphin and dynorphin, enhancing inhibition of noradrenergic release, taking our foot off the gas pedal. We reduce the drive, the excitatory drive, reduce the pulsatility of GnRH release and the levels of release, and reduce LH and FSH. So balance among all these at any one point in time, of course, produces the plasma level. Now let's consider another type of paracrine, because those were all neurocrine that we were discussing before. Now let's consider a paracrine type of interaction by looking at axon terminals at neurohemal junctions. In this case, we're going to look at an interrelationship between vasopressin terminals, where the vasopressin is co-localized and co-released with dynorphin, still an opioid-mediated mechanism, and oxytocin. So this would be the posterior pituitary that we would consider. So I just inserted this image of an electron micrograph of the posterior pituitary terminals forming the neurohemal junction. Here you see a red blood cell in the lumen of a capillary. Here you see a capillary endothelium. You can kind of see that the two cytoplasmic membranes are separated, the one away from the lumen called AB luminal. You abduct somebody, you're away from it, so the AB luminal, abluminal membrane is there because it's away from the lumen, and the adluminal is here. We can see the space in between. This becomes narrowed so that the two abluminal and adluminal membranes are together. This forms the little window, the fenestrated capillary in the posterior pituitary that we described before. So here you see these large secretory granules. You can also see some small neurotransmitter vesicles or other vesicles here that might have been depleted and taken back up, and they've got to be recycled to be recharged with the neuropeptides. We've got to recycle that membrane. Anyway, here are the large secretory vesicles that we're talking about. We're considering release here and then diffusion on over to bind to receptors on a nearby axon terminal and produce an effect. So it is paracrine. So you can see there's plenty of space. Well, maybe not. Interstitial space is voluminous, but when you look at it two-dimensionally like this, it doesn't seem to be much interstitial space here between these axon terminals at the neurohemal junction for the events to occur, but plenty of space here between at the neurohemal junction, so diffusion out here to bounce around over here and hit the receptors and have an effect. So let's go to the next slide where we've got the legend for this, and we can see that when vasopressin, here's the action potential coming down, the voltage-gated calcium channels with the calcium influx, and the potassium channels with the potassium efflux. So potassium leaving will hyperpolarize, make it more negative inside. Calcium influx, of course, is directly related to the exocytotic release. So these are the two targets that we've discussed all along. So the co-release of the vasopressin and the dynorphin, making it seem like, oh gee, the vasopressin knows only to go to the blood vessel and be washed away, and the dynorphin only wants to hang around in here and go there. We know that both of these are creating an interstitial fluid concentration. It's just going to bounce around all over, and as it enters down its concentration gradient into the plasma, it will be washed away with the blood. Remember, we don't have any purposeful directional movement of these molecules. It's all diffusion and bulk flow, so everything will go everywhere, and ultimately the blood flow is the key factor in keeping the concentration gradient, as we've said before. Anyway, let's allow that. The major effect of the vasopressin is going to be mediated through its distribution through the blood. We can say that. That's what this arrow indicates. The dynorphin that is co-released can have two potential effects if it reaches these locations and binds to its receptors in auto-inhibition, so an autocrine effect where it can target the potassium channels, causing greater potassium efflux, hyperpolarizing, reducing release, as well impacting the calcium channels, making it more difficult for calcium to come in when an action potential comes, or less likely to have sufficient amounts of calcium to enter, so exocytotic release is reduced. And then the paracrine effect on the nearby oxytocin terminal, again doing the same thing, and I'll have to check the legend to make sure I have this correct. Is it an auto-inhibitory effect? The dynorphin, which is co-released, binds to the kappa receptor on the oxytocin nerve terminals. Okay. As we're just talking about, that decreases the calcium, so it's closing off the calcium entry by direct action on the calcium channels or indirectly by acting on the potassium channels. The net effect in either case is a reduction in calcium entry into the nerve terminal in response to the depolarization by the nerve impulse, the action potential, and reduction in oxytocin secretion. It may also regulate the release of vasopressin by the same mechanism, so we were safe considering it as an auto-inhibitory effect or a paracrine inhibitory effect on the release of oxytocin. So we continue with some examples. The central injections of substance P suppresses the GH secretion, as we saw on the table. No effect on prolactin levels, and peripheral injections will increase the release of both. So differences between central and peripheral injections and mechanisms of action. The neurotensin was another example. The central injections inhibit the release of GH and prolactin, actually by increasing the levels of somatostatin in the hypothalamus. And so many examples for GI peptides, CCK, increasing GH, prolactin, and ACTH, decreasing CCK, decreasing TSH, TSH, LH, and FSH. Central VIP, increasing GH, prolactin, and decreasing LH. Neuropeptide Y inhibits release of GH and LH and has no effect on prolactin, ACTH, and FSH. Angiotensin II, stimulating ACTH. This is one I would like you to realize and understand, that angiotensin II can stimulate synthesis and secretion of ACTH. The angiotensin II would be in the plasma from the peripheral renin-angiotensin system. So we'll build on that a bit later, but for now, just from this slide saying, what do I need to remember? Angiotensin II does stimulate the release of ACTH. The effects of bombesin and secretin. If you want to take the time to memorize all these and you can remember them for the rest of your life, go for it. It's obviously a point of reference, but certainly we want to pick a few examples to make certain points. So the visceral cognitive and behavioral effects of the neuropeptides. The neuropeptides modulate the visceral function of the autonomic nervous system and the cognitive and behavioral functions of the central nervous system. So hunger, thirst, sexual arousal, GI, and circulatory system functions are affected by the neuropeptides. Again, we're building on this idea of a coordinated response of the organism to alterations of external and internal environment, such as they might impact survival and reproduction. Learning and memory are regulated by neuropeptides action in the neocortex, the hippocampus, and other limbic areas. We saw the nucleus accumbens, and a point made about CCK being co-released by dopamine, And then let's just take a final look at the endogenous opioids again for the analgesic effects, so we get an appreciation for circuitry that might be involved. So the first use of the opioids and opioid agonists was in treating pain as an analgesic. So they activate descending inhibitory pain pathway from the thalamus to the spinal cord, and thereby inhibit the ascending pain pathway in the dorsal horn of the spinal cord. So we'll consider this without trying to become professionals in neuroanatomy. So there are two spinal thalamic pathways. There's a newer one that has emerged in higher level organisms, neospinal thalamic, and here we pick up sharp stabbing pain, so discrete pain, stimuli, and distribution. And then an older system, the paleospinal thalamic system, thought to be the first one to develop, so that at least there's some distinctive sensory component of a risk of harm to you as the organism, threatening your survival and reproduction, right? So this is now for humans associated with the dull chronic pain, and therefore it's the system involved with chronic intractable pain, nothing else that you can really do about it, so you have to use the opioids, which we know are addictive, to treat this in human patients that suffer from intractable pain. We hear stories all the time of people getting addicted to pain pills and so on and so forth. So this helps us to understand how all of our movie stars end up in trouble, falling off the stage or getting hurt in a stunt, taking a few pain pills, and next thing you know they're addicted to it, and we read that they're checking into a rehab center because they're addicted to their pain pills. Anyway, this is how they work. Here's the sensory system coming into the spinal cord. The first sensory neuron will have synapses in the gray matter toward the back or dorsal gray horn of the spinal cord. The neurons will pass, the second neurons, called second order sensory neurons, will pass information up to higher centers, ultimately to the thalamus, and then from the thalamus to the cortex. So there's spinal thalamic pathways that we're considering, and thalamocortical pathways, until we finally realize that here up in the cortex we have the conscious awareness of it. And what we see, sorry, did I show that one going up? I shouldn't have. It's just over here. It crosses at the level of the spinal cord, and the spinal thalamics ascend on the opposite side. Some of them have branches or collaterals of the axons in the synapse on different nuclei along the way associated with the response to pain, control of pain, and reversal of pain or blunting of pain when appropriate. And of course, intractable pain is a pathological situation. So we see there's the reticular formation of the midbrain and of the pons that are significant areas where we have synapses from this polysynaptic pathway. But there's a descending pathway from here, from the periaqueductal gray, down to the nucleus raphe magnus of the pons, and the synapse there onto the next neuron, and the descending circuitry coming down to the spinal cord and having an inhibitory effect on the first order neuron carrying the pain information in onto the second order sensory neuron that takes it up to the thalamus, and of course then finally to there. So if you can block it here, it's called the gating mechanism. If you can block pain at the level of the spinal cord, it never even gets up to the thalamus for a subconscious level awareness of the dull pain. So basically, this is the opioid circuit here. Down to the nucleus raphe magnus. So opioids would be acting here. Then there are local interneurons, opioid interneurons, in the spinal cord itself. So there are opioid receptors right here in the spinal cord. So these 2 points of action of the opioids on the control of pain here in the nucleus raphe magnus of the pons. Excuse me, that's the medulla. I'm supposed to be an expert in neuroanatomy, and I failed. Sorry. That is the medulla oblongata. All these things filling it in there confused me. I just didn't read the legend either. Okay, so here in the medulla, the nucleus raphe magnus, the exogenous opioids that we'd be giving to treat intractable pain would be acting here and here at the spinal cord. So this analgesic effect of the opioid peptides is through inhibiting neurons from firing along the paleo-spinothalamic pathway, and as a result have an analgesic effect. They stop the pain signal from reaching the level of the thalamus, from exiting the spinal cord actually, to the level of the thalamus, and therefore it can never reach the cortex. Substance P is one of the main transmitters of pain signals as well, so we need to keep that in mind. A lot of research on studying substance P for the control of pain as well. Factors that stimulate in substance P receptors are not associated with any type of addictive quality of the neural systems, the reward neural systems, as are the opioids. So there's hope for substance P acting agents to control pain without that risk of addiction. We're not there yet. Still a lot of opioids out there for people to take to alleviate their pain and become addicted to. Factors that stimulate the release of endogenous opioids will decrease pain perception. This is one of the mechanisms of action of the percutaneous electrical stimulation that will cause enkephalin release, one of the opioids. Acupuncture causing beta endorphin release. Stress causes an endogenous opioid peptide release in the brain and spinal cord that will cause a stress-induced analgesia. So if you were really stressed, survival is really severely threatened. You want to be able to take a little bit of pain so that you can escape as you switch from fight to flight, or whether you're going to fight and then try to flight as well, or survive to reproduce. You know how it is. So the beta endorphin release during running will also have analgesic and euphoric effects. There's another figure in the text that we won't take time to look at that compares the runner, couple of runners and their plasma levels of beta endorphin. There are effects on the autonomic nervous system, so the endogenous opioid peptides will depress respiration, reduce gastrointestinal motility, modulate heart rate, blood pressure, body temperature, and inhibit catecholamine secretion. So this is kind of an interesting array of effects that, if we took a close look at them, should be contributing to the stress response under severe conditions. There are cognitive and behavioral effects, so the mood states and the emotional aspect of pain and stress reduction are associated with mu receptors in the limbic system. The opioid suppression will produce a feeling of euphoria when stress or pain is inhibited. So the opioids might also regulate learning and memory. So what we would like to think is that in times of dire stress, true, intense, and severe threats to survival, we want to have selective learning and memory so that we can filter out distractions and end up with very sharp memories of a successful survival strategy. Doesn't always work that way, but my understanding of the system is that that is the goal. We know that biology isn't goal-oriented, but we always speak of it that way. This should be the coordinated response, so that if an individual organism survives such an intense situation, there's a filtered learning and memory to have a reliable survival strategy that does not have a lot of a lot of noise in the signal, right? So the opioids contribute to the filtering system to reduce the signal to reduce the noise and enhance the signal-to-noise ratio. Signal kept sneaking in there, didn't it? So you want to enhance the signal-to-noise ratio so that you have sharp learning and memory of the best survival strategy under such a situation. So your coping mechanisms. So the opioid addiction is caused by a change in opioid receptor sensitivity by downregulation of the receptors. So taking opiates is not going to provide you a good filter on learning and memory so that you have sharp recall of just the critical information. In other words, getting high on heroin and studying isn't going to make you perform better on a test, I would predict. And then the neurohypophyseal peptides, the oxytocin and the vasopressin, are mainly located in the magnocellular neurons, as we know, of the PVN and SON, respectively. And they have a range of central peripheral effects on visceral, cognitive, and behavioral aspects. So we're just going through all these specific examples, again, reinforcing that general concept that we took in at the very beginning, that we want a coordinated response to external and internal environmental changes such that it is appropriate to the environmental change. So the oxytocin is going to stimulate parturition, regulates grooming and feeding behavior. Hard to relate that to humans. Rats have very specific grooming behaviors, so we observe that in rats. Feeding behavior, we could see the stimulation of parturition and then initiates milk injection, so contributing to an appropriate feeding behavior such that when milk is ejected, food consumption occurs to replace the milk that was ejected. So we can kind of make sense of that. Regulates GI and cardiovascular system, typically consistent with the hemodynamic demands and body fluid demands. And it doesn't always work so well in pregnancy and lactation. It also inhibits the memory processes, so very important during partition, very important to forget some things about delivery so you might ever get pregnant and reproduce again. More so for the female, obviously, but well, maybe males don't have to forget too much of it to be more than willing to contribute to the reproductive process again. But certainly for females, it's very important to blunt the memory of the delivery event. At least, I don't know, some guy probably made that up, so they're more likely to reproduce again and have another child. I don't know. We're trying to make sense of it when we probably shouldn't. So the vasopressin regulates blood pressure, facilitates avoidance and reward learning through its action on the hippocampus. So what we are trying to make sense of here is the effects of vasopressin on regulating blood pressure are typically related with severe blood loss or some blood loss. So if you lose some blood, survive, you definitely want to avoid that situation again, and remember your survival strategy. I guess maybe that's what we'd be thinking of there. And the list goes on, and this is mostly from the table, so I'm just going to quickly go through it. Somatostatin, the receptors are found mainly in the highest concentration in the cerebral cortex and the hippocampus. It changes both motor excitation and sedation, regulates body temperature, facilitates memory consolidation, and retrieval. So this somatostatin that inhibits growth hormone secretion, growth hormone promotes metabolism and stability of the organism. Does all this fit into that? Well, we shouldn't always be looking for that. Remember the homology of function hypothesis that we had mentioned before. Just because it's somatostatin and its actions at the pituitary in the cerebral cortex and hippocampus, use the same name because it's the same molecule, but we don't necessarily have to expect a function that would be integral to that primary function of the hormone at the anterior pituitary. Sometimes maybe yes, other times maybe no. GHRH, growth hormone releasing hormone, stimulates feeding in the rats. You can kind of make sense of that. Corticotropin releasing hormone, its nerve pathways, the extrahypothalamic neuronal systems project from the hypothalamus to, for example, a limbic motor kind of an area, the bed nucleus of the stria terminalis, the hippocampus, the amygdala, the cortex, and the brainstem nuclei, and it modulates electrical activity of neural cells, similar to what we have been describing with our other examples, in the cortex, hippocampus, locus ceruleus, and hypothalamus. Now the central effects of CRH through all these extrahypothalamic pathways most often is very consistent with the stress response system. It really is one prime example of the homology of function hypothesis, and nearly all of the functions of the CRH in the brain contribute in some way to a response of an organism or a change in the organism or its ability to respond that would be consistent with responding and surviving in a stressful situation. However, it can be pushed into pathological ranges, so risks, suspicions that it's involved, for example, in the hippocampus, in anxiety and panic attacks. So there's always the possibility of the exaggerated, imbalanced, homeostatic type of a response mechanism. So depression, anxiety, and panic are three areas of clinical relevance considered for the CRH, central CRH system. TRH, its highest concentration in the thalamus, the hypothalamus, the brainstem, olfactory lobe, spinal cord's got an antidepressant effect, inhibits sleep, increases body temperature, elevates blood pressure, and increases muscle tremor. So again, the challenge before you is to put these together into some type of functional response systems, and do they make sense in a coordinated response to contribute to survival, increase the likelihood of survival or reproduction, and or fit in there, right? LHRH, luteinizing hormone releasing hormone, another name basically for GnRH, gonadotropin releasing hormone, found especially in the median eminence, the limbic system, along the olfactory pathways, and acting centrally, it facilitates sexual behavior in steroid-primed female rodents and primates. So that basically is consistent with reproductive functions. Some of the adenohypophyseal hormones also act as neuromodulators, such as prolactin, inhibiting the sexual behavior and facilitating parental behavior. So that makes sense. It might act through dopaminergic neurons in the inhibition of male sexual behavior. So contributes to reproduction, although it may not all be consistent, especially in males, with the promotion of lactation. So prolactin is a good name for this hormone for its ability to promote lactation, but that might not be the best name for what the hormone does overall behaviorally and cognitively. This slide is showing us some of the gut peptides, substance P, VIP, CCK, for example, producing analgesia and hypothermia, neurotensin, and let's not worry about these. I think we've covered enough information. You've got enough to try to make sense of and memorize. I guess what we're doing is through examples, long list of examples, we're convincing ourselves that the vast array of peptides that we've been looking at and considering have very global effects, some distinctive, some with overlaps, on the entire organism, mediated through the central nervous system and coordinated with any effects that there might be on peripheral organs. Remember, the anterior pituitary is included in the peripheral organ list there, to contribute overall to the coordinated response of an organism relevant to survival and reproduction. There's other neuropeptides as well, and as I said, we're trying to limit as much as we can, and we